Now, your research has covered many fields of economics, including health economics, of course. I was just wondering where you see health economics in terms of the broad field of economics in general, and how important do you feel it is in your interest in economics in general?
Well, if we think of economics as the allocation of scarce resources, as we used to say, I think that term is a little passé, but I think it's still an important part of economics. Certainly, the field of health is a major one, both in terms of satisfaction, in terms of in terms of the resources needed. In fact, if anything, the role of health in the economy is becoming much bigger than it was when I started the field. Partly, this is a result of technological change, of course. Essentially, there are more things which you can usefully spend resources on health. Partly it's also, this is a little more problematic, a recognition of the importance of health considered as an economic good. In part, this is due to new methods of approach for measuring the importance, and namely what's called the value of a statistical life. And the figures are surprisingly high. So, for example, some colleagues and I, for reasons of nothing to do with health per se, were trying to estimate the wealth of economies. This really arose out of attempts to discuss sustainability, so it arose really in a different context. Nevertheless, we wound up saying that the bulk of wealth is in fact health, that this is larger than all the other recognized sources of wealth put together, the machinery, the reproducible capital, even the human capital is swamped by the measure of health. And while this is a controversial point, I'm increasingly believe that this is a correct assessment.
So how did you specifically come to work on medical care markets?
Health insurance was just spreading. Hospitalization insurance had become moderately widespread. Health insurance outside the hospital was just beginning at that point. And of course, for various accidental reasons, I knew something about insurance. I was interested in the economics of risk-bearing in any case, and I happen to have some other experiences with insurance. So the idea of health as an insurable risk struck me as being completely obvious. That was didn't think about it. Obviously, you have something which is going to affect a few people very much, and most people a moderate extent, and it was not predictable, at least not highly predictable. So it's actually an ideal example of insurance. And one of the questions was, why wasn't there more extensive insurance already? It's a pretty obvious question. I began to realize that with these problems of incentives, and I began to read and grope. And one day it finally hit me. What was the really central feature here? And there were several different aspects. One was the relation between the insurers and the physicians or the insured. How do they know? How does the insurer know how much you really need? Put it in everyday terms. There was the obvious question that people have some idea of their health, and therefore they might, if you think you're likely to be sick, you'll insure yourself more. This was something which already occurs in life insurance, so it was not. And these concepts, I had heard about them. Moral hazard and adverse selection were concepts that were already known in the insurance. I did not invent those words. They were borrowed from insurance literature, as I think I made clear. And then there was also the question: how do you realize it was a question of guaranteeing that you get good medical service when you get it? There's one of the incentives on the part of the physician to treat the patient properly. After all, by definition, the physician knows more than the patient. That's why he or she is the physician and you are the patient. Yes. That's intrinsic in the relationship. And how do you guarantee it? So finally, suddenly struck me all of these. It just hit me one day after reading and pondering and starting to write a rather routine examination, trying to bring the modern theory of risk-bearing into the picture. It suddenly struck me the point was there was a difference in information between the two parties involved. And this occurred, as I've just said, in several different levels. So the medical system was rife with this. All of these existed elsewhere, but this was probably more important in welfare terms than most of the other examples. I mean, you have a problem when you get your car repaired as to whether the mechanic does a good job and whether the mechanic finds faults which don't exist. And, so you have some parallels, but the magnitudes are simply not of the same order. So this gave rise to the idea this was a set of principles which had other applications, of course, but certainly came within full force into the health business and changed the nature of it very completely. Well, I say the general principle of asymmetric information turns out to have wider applications. In fact, I must say I rather kick myself for not seeing immediately the applications in finance, which of course did emerge in the literature, but that was a primary example of which recent history, shall I say, shown its importance. I think when we understand that in the medical field, then I think we will have lessons of great importance for other fields, because I think it's also true in most cases that asymmetric information is not going to be cured exclusively by very ingenious incentive schemes.
Now, in 2009, you co-authored an article titled "Towards a 21st Century Healthcare System." I was wondering, what are your thoughts today on what is needed in the 21st century for a healthcare system?
Well, now this is partly a question of theory, but mostly a question of practice and experience. That the countries that have shown the greatest ability to provide good health care and yet moderate, not abolish, but moderate the increase in costs, have been those with fairly centralized systems, single payer systems of some kind. I don't necessarily mean that the government operates the medical system as it might in the United Kingdom, but it's at least it plays a big role in determining the financing. So it's a single payer system. And the United States has shown an incapacity to control costs, and is not paid off in extremely good performance. Whatever it's worth, the complaints, if you ask people how they're satisfied, there's a higher level of dissatisfaction. Now I don't know how to take those things, but if you look at objective performance like longevity and infant mortality, the United States, its longevity is comparable to Cuba's, which is not exactly a highest compliment that one can pay, to put it mildly. Yeah. So, and on the other hand, our costs are, as I say, approaching 20% of the GDP, which and certainly there is a part of it, maybe only 5%, but still not zero, which is just due to the complexity of the system. The administrative costs are enormously higher in the United States than they are anywhere else, and it's part of the complexity, but also the gaps in coverage. All these things suggest to me that a single payer system would permit a more uniform coverage, and at the same time give you the opportunity to control costs by disseminating standards that are more uniform.
Do you have any final reflections, Professor Arrow, for the conference delegates, perhaps on what you would like to see researched in the next 50 years of health economics?
Well, I think as I've repeatedly hinted, the questions of social interactions within the medical community is probably the most, and the recognition of some kind of benefit-cost analysis, some kind of trade-offs. How you bring them into the community without violating the underlying spirit, and yet recognizing that you're going to have to, there's a limit to what you can do, is I think the thing. And I think probably the mere act of discussing it is already an important part of the issue, of the educational issue.
Okay, thank you, Professor Arrow, and on behalf of the Sydney Organising Committee of the International Health Economics Association World Congress, and all the delegates, of course, who will be listening to your interview, thank you very much indeed for sparing the time today.
Thank you. Good.